for having me. Interestingly, Dr. Han was part of this case, so he gets to relive this with me. So I have no conflicts of interest related to this. So I'll just start with the case. So this is a 74-year-old female. She presented with left leg claudication, less than a block. She had the usual kind of cohort of comorbidities, and she was on aspirin, Plavix, and a statin, and she was a former smoker. On exam, she had a palpable femoral pulse, but no palpable pedal pulses and no tissue loss, so she was claudicant. And her labs elevated creatinine, but otherwise pretty normal. We obtained some non-invasives, which kind of confirmed that she had claudication, decreased ABIs, and an arterial duplex, which showed it was a SFA and popliteal artery stenosis. So what are the treatments? Of course, conservative, this should be kind of the first. So trial of exercise, Celastazol, see how she does with that, structured exercise program. She comes back a couple of months later, and really her symptoms haven't improved, and she's less than 1 block. So we offered her an intervention. So here are just some representative cuts. So here you see her aortoiliac segment, which looks relatively healthy. Going further down, her common femoral and the start of her superficial femoral artery, which is also okay. And then her disease is more distal, so she has a kind of multifocal stenoses of her distal SFA and into her popliteal artery. And they are, I don't know if you could appreciate it with these contrast windows, but they are very calcified. And then she has a 2-vessel runoff. So kind of my algorithm for these treatments is these types of lesions are to atherectomize and debulk the lesion to try to avoid a stent in that area. So that's what we did. We used a Medtronic Hawk device, which, from what I'm about to tell you, I'll tell you I love the device and I think it works great, but obviously I'm going to have a complication with it if I'm here, followed by balloon angioplasty. And so we actually got a good result just from the atherectomy alone. The issue happened. Let's see if it's on the next slide. So a couple of things before I get into it. So it was very calcified. We had a hard time tracking the atherectomy, and as you know, the Medtronic device is directional, so you rotate the device, but it wasn't really a one-to-one feel. So there was probably a lot of torque building up in the device, and we did at least 4 cuts each time. When we tried to retrieve the device, it got stuck at the start of the sheet, and the kind of correct thing to do is probably to kind of assess it, stop, and see what's causing it. We tried to rotate it back, didn't really work. We tried to get rid of the wire wrap or whatever was causing this, which also didn't work. And probably the thing that we shouldn't have done is kind of just pulled harder, which is kind of a, I won't say who did that. So that's what happened. And here's kind of representative cut of what happened. So the device of the atherectomy device, the head of it broke, and it was thankfully still on the wire. So we had a wire more distal, and the head of the device was on the wire, and it broke right past the cutter, if familiar with the device. So it broke right there, and so the rest of it came out, and our sheath was still, into the proximal SFA. So at this point, we obviously had like a retained foreign body. I think one benefit was it was still on a wire, which probably made the salvage a little bit easier. So what do you do in these situations? So just as general advice, this is my first year of practice when this happened. I think I was a couple months in. I was with a intern at the time, and so the first thing I did was call for help, which I think when you start your in attending, and even as you move up, that's never a bad thing. And if you have partners that can help you, that's going to really benefit you. Sometimes you just need a second pair of hands. So the first thing I did was call Dr. Han because he was next door, and so we kind of discussed the options. So the good news is the patient wasn't bleeding, and we at least had time on our side. So we made sure the ACT was therapeutic. We kept the patient well heparinized, and then we kind of discussed the options. So option number 1, which obviously is not a good option, but in other situations to do nothing, but we can't really, that's going to occlude the vessel. Number 2, if you have smaller pieces that break off and you're really kind of, maybe the patient's not doing well and you just need to get off the table, you can try to place a stent there and just push it to the side of the wall to kind of exclude it from the circulation. And in kind of a damage control situation that, isn't potential. This is not a good option for this case, of course, because that if you've seen the head of the device, it's very bulky and it's going to create a stenosis there. And that's kind of a bailout option at the very end. The other options we have are endovascular retrieval, which is what we chose. So I'll talk about that in the next slide. And then the final option, which is important, is surgical removal. So again, just doing a cut down. It could be a simple cut down, which you can do under local if you're in the cath lab, and just physically removing the device. And I think that's always something to really consider, because rather than struggling and dissecting the vessel and putting in snares and things like that and making it worse, sometimes a simple cut down may be the way to go. So for this one, we did try the endovascular retrieval. So what are your options? So we ultimately went with a snare. And I'll talk about that in a sec, kind of how we did that. But we were able to retrieve it with a snare. In general, some other options you have are, especially for the venous circulation, is using endoforceps. It's not really good for arterial in a lot of instances because it's a big sheath, talking about like around a 20 French sheath. And if you're going up and over, it's not going to take that bend. But for venous, if this happens to you, if you break a device, like especially during IVC filter removals, endoforceps are potentially an option there. There's techniques describing using almost like a filter and kind of pulling back on it, which sometimes works more for clot, but it's not really going to work in this case. And then the other thing you consider is embolectomy catheter, or using a balloon and kind of dragging it back as a system, which for maybe something smaller you could get away with. But again, in this case, I think the most viable option that we had was a snare. So the one good thing we had is the device was still on the wire. So we actually advanced our snare over the wire and through the sheath, and then we kind of basically cinched it down right over the device, head of the device. And then we pulled both the wire, the head of the device, and the snare out when it was closed in one system. We got a little lucky in that the device went into the sheath, so we didn't have to lose our access to our sheath or anything like that. But potentially, even if we couldn't get into our sheath, you could potentially put a buddy wire. If you have a large enough sheath, then you don't necessarily have to lose access. But in this case, we snared it and we were able to pull it out, and she did very well. I also considered doing a cut down on her, but for her, she wasn't really a good candidate for that. She was kind of morbidly obese. She had pulmonary hypertension. She wasn't really tolerating, the sedation very well. She's kind of moving around a lot, so it wouldn't have been easy for her. So anyway, for her, we snared it and we were able to get the device out. She thankfully otherwise had an uneventful recovery.
I think it's a very interesting technique to keep in the back pocket. You heard about snares, you heard Dr. Grunstein talk about it earlier. This is slightly different, right? We're talking about a device that is still on your wire, but that has broken off. You might see this with balloons once in a while, or a stent that migrates when you're trying to do something. So this is a technique that really helps you recapture the thing that's on the wire itself. So you're putting the snare over the wire, but the catheter for the snare catheter is not going over that wire. So the snare is going without any wire on the inside, buddy next to it, and then going into the sheath so that the snare itself is around the wire. So when you exit the sheath, you can open the snare catheter over, and you know that you're around the actual wire itself, and then you can push that over the device and then cinch the thing back down. Does that make sense? Yeah. So I think it's a good thing to keep in the back of your mind. Why do you think it broke?
So I think with the device, you rotate it, as you know, because it's a directional blade. I think probably over rotated a little bit, and then it got caught in the sheath and right at the start of the sheath. And so I think when we were pulling back, it's kind of a weak part of the device that broke off. Yeah. So kind of I think ways to avoid that is if it's not rotating well, rather than just trying to rotate it, maybe take it out of the system, try to get the tension off. You shouldn't do more than 4 cuts, or maybe even less if you're having that issue, to avoid that potential issue.
So, got this narrow grip. Your device is dislodged, sitting at the proximal exit. So your destination sheet or whatever your intervention sheet is somewhere at the proximal CFA or distal coming ankle. So where it's fractured, and if you yank on the snare and you pull it, but you're not scared if the blade would cut the CFA or tear the external iliac artery, or you just based on the feel, what were you guys thinking?
Yeah, so no, it's a good point. So The end of the sheath, I think, was either in the common or proximal SFA. We obviously did it under direct fluoro. So she had a pretty big common. I think if we had done this in a smaller vessel or an area of stenosis, definitely we could have caused more damage. But I think the vessel where we snared it, which is an important point, was relatively healthy. And doing it under fluoroscopy and watching watching the snare and the device go back into the sheath are important.
It's not a similar situation, but my device didn't fracture at all. It happens when I learned that if you do 10 torques, then make sure you do 10 the other side, whatever. So what we did was we actually trapped the whole system in the SFA and got the whole guiding catheter as far as we could go. Then we trapped the balloon and pulled the whole thing up. So I was scared about whether, if your cutter, your pull back or whatever is sticking out the blade with a cut the CFA.
Yeah, no, I definitely think that's a possibility. I think because ours was still on the wire, it kept it relatively straight in the middle of the vessel. So
I think it's always interesting because the point at which this starts happening is what do we do at this point, and it's always pull harder, and that never seems to be.
yeah, another good point of advice. If it doesn't feel right, the answer is not pull harder. That usually just results in complications.
So one question. So I think your solution was very eloquent, and I think it's, what if it didn't work? So I was thinking, I didn't know that it would end there. I thought maybe a second complication, but I was thinking, what if you upsized your sheath, threw an 035 down and took like an 8 French sheath? Would you have been able to pull it out through the 8 French sheath when you first felt the resistance? And the other option is, what if you came pedal and pushed it up with the balloon? Of course, this is after you'd broken it. If you couldn't snare it, would those be two options as well?
Yeah, I think that's a good point. So we had I want to say it was a 7 French in there, but upsizing to an 8 French, so you have room for another catheter, wire, or even a balloon to try to inflate past it and then pull back into your sheath is an option. Going pedal on her, you're kind of limited by the sheet size, but if you're just using the balloon, like you said, that would potentially work too.
So there is like an interesting way to change your sheath at that point, right? You have an 014 wire up and over on that side, and what my friend Jordan Stern over at Stanford is the one that taught this to me. But if you are stuck in a situation where you only have a 014 wire up and over, and you're trying to exchange that out for a bigger sheath, you can put 3 014 wires within the same lumen of the sheath, and that almost takes up the same diameter as the 035 wire. So put 2 more 014 wires down, exchange out the whole sheath, and over that you should be able to send the 035 sheath up and over. So you can do an exchange over that system in this situation if you did have to upsize.
Yeah, that's a great trick.
Yeah.
And also, you can also anchor 014 balloons, and then as you deflate, you can feed the sheath over that.
Yeah.
It gives you more
Yeah.
air.
Yeah, definitely.
Well, thank you very much.
Thank you.